Welcome to this training on crisis prevention and intervention through using a mental health advanced directive. This training is appropriate for a wide range of audiences, including persons interested in having a mental health advanced directive, people helping facilitate the completion of mental health advanced directives, agents, care providers, tribal partners, first responders, crisis providers, certified peer specialists or peer supporters, people with lived experience, and family members of people with mental health concerns. In this training, we will explain what a mental health advanced directive is and the main parts of a mental health advanced directive and why one matters. We'll understand what a mental health crisis is and what can cause one and how to recognize the signs. We'll describe how a mental health advanced directive can help catch early signs of a crisis and how support people can use it to speak up and guide care during a crisis. We'll also explain how a mental health agent can use the MHAD to guide decisions and how they can make decisions based on the person's values and preferences. So let's dive in. This training is about a very helpful tool in mental health care called a Mental Health Advanced Directive, or MHAD for short. An MHAD is a legal document that lets people plan ahead for their mental health treatment. It's used when someone might not be able to speak for themselves or make decisions during a mental health crisis. Mental health conditions can sometimes cause confusion, fear, or stress that makes it hard for a person to think clearly or explain what they need. That's where an MHAD comes in. It allows a person to write down important information ahead of a potential crisis, like what treatments or medications help them, what treatments or medications they want to avoid, and who they trust to make decisions on their behalf if they are unable to. The information in the MHAD can also help a person feel safer and calmer before a full crisis occurs. An MHAD does not just help the people who wrote it. It also helps the people who are trying to support them. Doctors, nurses, therapists, and crisis workers don't always know the person's history or what works best for them. An MHAD gives clear guidance to the care team so that they can make better decisions and respond in the most helpful way, especially during a mental health crisis or when providing help before a crisis fully occurs. It's important to know that an MHAD is a legal document. That means it has power, and it must be taken seriously and included in a person's medical records. Care teams are expected to follow the directions in an MHAD unless there's a very specific reason why they cannot. Having an MHAD helps people stay in control of their mental health care even during the hardest times because it makes sure that others know how to provide support that feels right. MHADs can be a powerful tool for individuals facing mental health challenges. This might include conditions like depression, bipolar disorder, schizophrenia, or anxiety, any situation where someone's mental health may fluctuate over time. MHADs are also incredibly valuable for people who struggle with substance use, whether that's drugs, alcohol, or both. These challenges can sometimes lead to unpredictable or high-risk situations, especially during periods of crisis. It's also important that we don't overlook the impact of trauma. People with a history of trauma, whether from abuse, violence, loss, or other deeply distressing experiences, may be more vulnerable when under stress. Trauma can shape how someone responds to crisis, and MHADs help ensure that their care reflects this understanding. While these are some of the most common groups who benefit from MHADs, they're not the only ones. There are many other conditions and life circumstances that can increase the likelihood of a mental health crisis, and that's exactly where MHADs come in. They provide a structured, compassionate way for individuals to express their preferences, outline their needs, and ensure their voice is heard. So if you're asked, who are MHADs for? The answer is anyone who wants to be prepared, protected, and empowered in the face of mental health challenges. An MHAD is a legal document that lets someone plan ahead for their mental health care, especially in case there's a crisis in the future when it might be harder for one to make decisions or to speak up for themselves. To fill one out, a person making the MHAD needs to have something called capacity. So, what does having capacity actually mean? Having capacity means that the person is able to think clearly and make decisions about their own care at the time they are making the MHAD. To have capacity, a person has to be able to do three things. They have to be able to take in facts about their treatment. For example, if a doctor explains two different types of therapy or medication, the person is able to understand what each one is. Next, they have to be able to compare the risks and benefits of those treatments. This means they can think through what might help, what might have side effects, and what feels right for them. They also have to be able to say what they want. This could mean choosing one treatment over another or saying they don't want a specific type of care based on their past experiences. It's important to know that adults are usually presumed to have capacity, so there's no need to prove capacity before making an MHAD. So let's say someone named Jordan is thinking about creating an MHAD. Jordan has a mental health crisis as a young adult that resulted in his involuntary psychiatric hospitalization. He was diagnosed as having schizophrenia and began treatment with medications that have helped him. When he returned home from the hospital, Jordan completed an MHAD with the help of a local peer specialist. Under Washington law, it is presumed that Jordan has the capacity to complete his MHAD, and his MHAD is presumed to be valid. His diagnosis and hospitalization do not change that. If he has another crisis, providers must honor his MHAD. It's also important to know that Washington State allows youth ages 13 or older to make their own MHAD if they demonstrate that they are able to make an informed decision about behavioral health care. That's because in Washington, teens have the right to make some of their own choices about mental health care. So if a 13-year-old knows what helps them during a mental health crisis, they can complete an MHAD to make sure that those preferences are honored. Now let's break down what's inside an MHAD and why each part matters. An MHAD usually has at minimum two important sections that work together to help someone stay in control of their mental health care. Let's start with the first part, advanced instructions. This section is all about writing down the person's preferences, the things they know from experience that help them, and the things they want to avoid. This might include medications or treatments that they refuse or that they consent to, life responsibilities that are important, like making sure someone checks on their kids, their pets, their home, who should help with bills while they're in the hospital. It's important to note that healthcare providers are not required to address these sorts of issues, as these sorts of life issues are important responsibilities for the agent to manage. The instructions in the MHAD are powerful and personal. They help doctors, nurses, and crisis teams understand the person as a whole and give care in a way that works for that individual. The second part of the MHAD is called the healthcare power of attorney. This is where the person can name someone they trust to make decisions on their behalf if they are not able to do it themselves. That person is called an agent. Now, here's something really important. Choosing an agent is completely optional. A person can still fill out an MHAD with just their advanced instructions, and that document will still be valid and helpful. But having an agent can make things go more smoothly, especially in fast-moving situations where decisions need to be made quickly. Together, these two pieces make sure that the person's voice is still heard, even if they can't speak up themselves. And that can make a big difference in how safe, supported, and respected they feel during a mental health crisis. When someone creates an MHAD, they are building a personalized guide for how they may want to be treated during times when they may not be able to speak for themselves. MHADs can include a wide range of care instructions, each one helping to shape a more responsive treatment plan. For example, a person might describe their mental health condition in their own words, noting what treatments have worked well for them in the past. Someone might write, "When I start feeling overwhelmed, I respond best to quiet environments in low lighting." These kinds of insights help providers tailor care to what's actually effective. MHADs also allow individuals to express clear preferences about medications. They can give consent for specific treatments, like I authorize the use of Risperdal if I start experiencing hallucinations, or refuse others, like I formally object to the use of Haldol. It causes severe side effects for me. Support systems are another essential part of an MHAD. A person might identify someone to contact in crisis. They might say, "Call my friend Keisha. She knows how to help me calm down." Or name a trusted medical provider that they want involved in decisions. This ensures continuity of care and builds trust. Please note that the proper release of information documentation must be complete and present for care providers to be able to make outreach to support people. For those in tribal communities, MHADs can include culturally grounded care preferences. That might mean involving tribal health providers or community leaders in requesting traditional practices as part of their support. These components, personal history, treatment preferences, support contacts, cultural practices, are the core of an MHAD. They turn a legal document into a living expression of someone's voice, values, and vision for their care. When discussing MHADs, it's critical to recognize the unique considerations for the American Indian and Alaskan Native communities, especially here in Washington State, which is home to one of the largest American Indian and Alaska Native populations in the country. MHADs are designed to center the individual's voice in their mental health care, but for tribal members, that voice is often deeply rooted in community, culture, and tribal sovereignty. So when creating and using MHADs, work to prioritize cultural responsiveness as a foundational principle. Let's break this down into several key areas. First is tribal sovereignty. Tribal nations are sovereign governments with their own laws, healthcare systems, and protocols. That means that MHADs must be developed and implemented in ways that respect tribal authority. For example, if a tribal member receives care on tribal lands or through tribal health clinics, their care should be approached in relation to that jurisdiction. Coordination between state systems and tribal entities is essential to ensure that these directives are valid, actionable, and culturally appropriate. Next is identification of tribal affiliation and connection to Indian healthcare providers. A person can use the MHAD form to identify if they are affiliated with a tribe and or if they receive care through tribal healthcare providers, also known as Indian healthcare providers. This information can help connect individuals with their tribal community and healthcare providers supporting their care. Connection to tribal cultural teachers or community providers must also be considered. Mental health care is not just clinical, it's also relational. Many tribal individuals rely on extended family, elders, spiritual leaders, and community members for support. MHADs should reflect these preferences by naming who the person wants involved in their care. This might include a tribal behavioral health provider or a cultural practitioner. Including these voices ensures that care is grounded in relationships that foster healing. It's also important to identify traditional, cultural, or spiritual practices. Western mental health models often focus on diagnosis and medication, but in many tribal communities, healing is holistic. It may involve ceremony, connection to land, storytelling, or traditional medicine. MHAD should allow individuals to include these practices as part of their treatment plan. For example, someone might request access to a tribal healer during a crisis. Incorporating tribal-specific considerations into MHADs can honor the sovereignty, dignity, and cultural identities of tribal individuals. This helps move from a one-size-fits-all approach to one that truly meets people where they are. It's also important to understand how MHADs relate to safety plans. While these two tools serve different purposes, they often contain similar content and can work together to support someone's mental health journey. Both MHADs and safety plans may include personal insights like known triggers. For example, someone may note that loud environments or unexpected changes in routine tend to escalate their anxiety. Recognizing these triggers help providers and support people respond proactively. They also include helpful interventions. A safety plan might suggest, when I feel overwhelmed, offer me noise-canceling headphones, let me take a walk outside. These same strategies can be included in an MHAD to guide care when the person isn't able to communicate their needs directly. Support people and providers are another shared element. A safety plan might list trusted individuals to call during a crisis, like a friend, peer support specialist, or therapist. In an MHAD, these names can be formally documented to help care teams know which support people might be helpful in preventing or calming a crisis. Note again that care teams need the appropriate release of information forms signed to talk to general support people, so it's important to make sure that these forms are available. Some individuals choose to include parts of their safety plan directly in their MHAD. This can be especially helpful when the strategies outlined in the safety plan have proven effective over time. For instance, someone might write, if I become suicidal, please follow the steps in my safety plan, including contacting my sponsor and removing access to medications. But here's the key distinction. While a safety plan offers guidance and suggestions to prevent a crisis or a return to using substances, the MHAD is a legal document that holds power when a person lacks the capacity to make decisions. It's the form that providers are required to follow to the fullest extent possible within the bounds of safety, legality, and availability. Together, these tools create a more complete picture of care. The safety plan helps prevent crisis. The MHAD ensures that care remains person-centered even when someone cannot advocate for themselves. Now let's talk about picking an agent and dive a little deeper into what an agent is in the context of an MHAD. An agent is someone the person chooses to be involved in their care and/or to make decisions for them. The agent is like a trusted spokesperson. They help to make sure the person's voice is still heard, even when the person cannot speak for themselves. The agent does not make decisions based on what they think is best. Their job is to follow the instructions and honor the preferences that the person wrote down in their MHAD. The agent can only make decisions for a person if the person has been determined to lack capacity by a professional. Once the person regains capacity, they are in charge of their decisions again. Choosing an agent is optional. If a person is not required to name an agent in their MHAD, a person is not required to name an agent in their MHAD. If someone does not want to choose an agent, they can still write care instructions that the provider will follow during a crisis. However, some people feel more comfortable knowing that someone they trust is able to step in and help speak for them. If a person wants to name an agent, it should be someone they trust deeply, someone who understands their values and will support their choices and is willing to advocate for them when things get hard. For example, a good agent might be a close friend, a family member, a partner, or even a peer support worker, someone who knows the person's history and truly wants what's best for them based on the person's own wishes. The agent must be willing and able to follow the directions in the MHAD. That includes what treatments the person does or does not want, who they want involved in their care, and what helps them during a crisis, and any other instructions that they've written. Where there is a question about what is written in the MHAD or where a decision isn't covered specifically in the MHAD, the agent should do what they think the person will want. To officially name an agent, a person must include them in the power of attorney for mental health care form. This is usually included at the end of the MHAD form. Let's take a look at another really important question. When does an MHAD become active so that it can help guide a person's care? When someone fills out an MHAD, they get to choose when it becomes active. That means they get to decide the point at which the MHAD starts guiding their care, and if they've picked an agent, when that agent can begin helping with decisions. There are three main options for when an MHAD becomes active. The first option is when the MHAD is signed. Here, the MHAD goes into effect right away, as soon as it's signed by the person in either a notary public or two adult witnesses. This does not mean the person is giving up control. They still have capacity and they are still in charge of their care. They can make their own decisions just like before. If they've chosen an agent, this option allows that agent to be involved right away. The agent can talk with the person's mental health or medical providers, review the person's records, like their treatment history or medications, and help the person think through choices and give support. This might be a good option for someone who wants help navigating care now, not just during a crisis. They might not be in crisis, but they want their agent to have access to support them in planning, attending appointments, or staying on track. This can be helpful if the agent is actively informed of the person's care and has up-to-date detailed information if a crisis occurs. As an example, someone might include, I want my mom to be able to talk with me and my therapist right now and help me plan my care, even though I'm doing okay. Even if a person doesn't need help now, this option can also help reduce barriers for the agent's authority when a person is in crisis, since it doesn't rely on a healthcare provider to determine a person is incapacitated. The second option is when the person is found to be incapacitated. Here, the MHAD only goes into effect only if and when a healthcare provider says the person no longer has capacity. This means a doctor or a mental health professional would need to evaluate the person and determine that, for now, they are not able to make informed decisions about their care. At that point, two things happened. The instructions in the MHAD must be followed by the care team. If there's an agent named, their legal authority begins. They can now make decisions, speak for the person, and help make sure the person gets the care they wanted in the MHAD. Before that moment, While the person still has capacity, the agent cannot step in. They don't have the power to act or make decisions until the provider makes that formal determination. Here, as an example, a person might say, if I'm in psychiatric crisis and have been deemed incapacitated, I want my MHAD to be activated and my agent to take over only then. This option gives some people comfort because they can keep full control of their care until they truly cannot speak for themselves. The third option is when certain events or conditions happen. This option gives people even more flexibility. They might say in their MHAD, my MHAD should go into effect when certain things start happening, and then describe those things. These trigger events can be anything the person knows are signs that they're heading into a crisis or starting to struggle. For example, they might say, when I stop sleeping for more than 2 nights in a row, if I stop taking my medication and start isolating from everyone, if I become verbally aggressive toward my friends or family. This option requires something else too. The person must say who gets to decide when those signs are happening. It could be a family member, a friend, a therapist, or someone else they trust. For example, they may say, if my sister sees that I've been hearing voices and not taking my medication, I want her to let my provider know that it's time for my MHAD to be used. This option works well for people who may not want to wait until they're formally declared incapacitated, but want to catch the crisis earlier before things get too overwhelming. So, which option is best? There's really no right or wrong answer. It's all about what feels right for the person and what helps them feel the most supported and safe. Some people want their MHAD to be active right away, so their agent can be involved as a support partner from day one. Others want to wait until they truly lose the ability to speak for themselves. And some people know the early warning signs of a crisis and want their MHAD to activate when those signs start to show up. No matter which option they pick, the most important thing is that the person has a plan that reflects their wishes and that their providers and supporters follow the plan. Now let's talk about what is a crisis. A crisis is more than just a bad day or feeling upset. It's a situation that is too big for somebody to handle by themselves. That person may feel totally stuck, confused, or overwhelmed. They may not know what to do, and the usual ways they cope just aren't working. In these moments, people often need help from someone else. A trained professional like a counselor, therapist, or crisis responder often help because they know how to support them and help them stay safe. During a crisis, emotions can feel very strong and intense. A person may feel a deep sense of fear, sadness, hopelessness, or even anger. They may feel emotionally flooded, like the feelings are crashing over them like a wave and they cannot think clearly. They may also feel out of control, like they're not able to make decisions or calm themselves down. It's also important to know that crises don't always mean that someone is a danger to themselves or others. Sometimes people in crisis are safe, but really struggling on the inside. Other times, there is a risk that that person might hurt themselves or someone else, and in those cases, there are extra steps to protect everyone involved. Either way, the goal is the same, to get the person the help they need as soon as they need it. So let's talk about what can actually cause a crisis to happen. Crises don't just appear out of nowhere. There are often things going on in a person's life or in their mind that lead up to it. These are external factors and internal triggers. External factors are things that happen outside of us, things in the world or in our environment that cause stress or pain. For example, increased stress might come from problems at school, work, or relationships. It builds up over time and can wear somebody down. Losing a loved one like a family member, pet, or close friend can bring huge waves of sadness and grief that can be difficult to manage. Traumatic events like being in an accident, witnessing violence, experiencing abuse can deeply affect a person's sense of safety and control. Major life changes such as moving, losing a job, going through a breakup can make someone feel unstable or overwhelmed, even if some of the changes seem positive on the outside. Then there are internal triggers. These are emotional or mental health struggles that happen inside a person. These can include depression, which can make a person feel very low, tired, or hopeless for long periods of time. Hopelessness, where it feels like nothing will ever get better and the future seems pointless. Anxiety, which is that racing, nervous feeling like something bad is going to happen, even if you're not sure what. Anger and panic can sometimes cause someone to feel out of control or scared of their own reactions. Hallucinations are when somebody sees, hears, or feels things that aren't really there. This can be very confusing and frightening. And delusions are strong beliefs that aren't based in reality, like thinking someone is out to get you when they're not. Other factors that can lead to a crisis as well, reactions to drugs or medications that can lead a person to have symptoms of panic, hallucinations, or other concerning issues. Some mental health diagnoses can contribute to a higher frequency of crisis episodes as well. Whether it's outside stress, something going on inside a person's mind, or something else, these factors can lead somebody into a crisis. It's also important to remember that a person should be believed if they say they're feeling like they're experiencing a crisis. Not all crises look the same. So even if a person looks like they're okay, if they say they are in a crisis, it's important to get them help. Here are some serious signs that someone must get help right away. These are red flags that tell us the person might be in real danger or struggling in ways that could put themselves or others at risk. First is attempts to harm or kill oneself or making plans to do so. If someone's trying to hurt themselves or if they're talking about having a plan to end their life, this is a medical emergency. It means they are feeling so hopeless or overwhelmed that they believe dying is the only way out, and that's when they absolutely need help or support. Next is threat to hurt other people. If a person says they're going to harm someone else, they should always be taken seriously, even if things seem calm. Sometimes people say things as a way to reach out, but don't take chances. Respond with care and action. Verbal or physical abuse of others. If someone is yelling at, threatening, or physically hurting others, it might be a sign that they are losing control of their emotions or are in a crisis. This behavior can hurt people around them and is also a sign they need help managing what they're going through. Excessive withdrawal from loved ones. Everyone needs space sometimes, but if a person suddenly pulls away from friends, family, or their usual activities for a long time, it can be a sign of deep sadness, depression, or fear. It's a signal that they may be shutting down and need somebody to check in on them. Not sleeping or eating for several days. Our bodies need rest and fuel to function. When someone stops sleeping or eating for days at a time, it's a warning sign. It can mean that their mental health is suffering so much that basic self-care is out of reach. Acute psychotic symptoms causing distress, like delusions or hallucinations. This means the person is experiencing things that aren't real, like hearing voices or believing something that isn't true. And those experiences are causing them fear or confusion. It can feel terrifying for the person, and they need medical attention to feel safe again. When any of these things are happening, it's important to get a person the help they need as soon as possible. This is where an MHAD comes in. It helps providers know how to best respond to a crisis in a way that's most likely to be effective for the person. It's important to know how a mental health crisis usually builds up. It's not like flipping a switch where everything goes from fine to out of control in 1 second. Most of the time, it's like climbing a staircase. Step by step, things build until it becomes a full crisis. The steps can be slow or they can advance very, very quickly. Noticing the early signs and responding the right way can stop a crisis from getting worse. Let's walk through each stage. The first stage is calm. This is the base of the staircase. The person is generally doing well. They're going about their daily routine, going to school or work, spending time with people they care about, eating meals and doing things they enjoy. Their emotions are steady and they feel safe and in control. So these folks are probably smiling, joking with friends, talking normally, or maybe doing something creative or relaxing. Next is the trigger. This is when something upsetting happens. It could be something small to us, but to the person it hits hard. They might feel uncomfortable, anxious, sad, or stressed. This stage is when noticing and responding with care can really make a difference. Examples of some triggers might be loud noises, a reminder of past trauma, bad news, a stressful situation, or a fight with loved ones. Next is agitation. Now the person starts to show signs of distress. You might notice physical changes. Maybe they can't sit still, they're pacing or fidgeting, their voice gets louder or more pressured, they may seem frustrated, snappy, or restless. You might see people clenching their fists, tapping their feet, avoiding eye contact, or giving short, sharp answers. Then we move to acceleration. Things are starting to move quickly now. The person might yell, cry, or refuse to follow directions. They may say things like, "Leave me alone," or "No one understands me." Here, they're feeling overwhelmed and may lose their ability to think clearly. You may see folks arguing with others, throwing things, stomping away, or slamming doors during this stage. Then we hit the peak. This is the height of the crisis. Emotions are out of control. and the person may be a danger to themselves or others. They may have trouble listening, reasoning, or calming down on their own. Here you might see people hitting or breaking things, running off, screaming, crying, or trying to hurt themselves. After the peak comes de-escalation. Here the crisis starts to come down. The big emotions are still there, but they aren't as explosive. The person might seem tired, quiet, or confused. They're no longer acting out, but they're not yet usually ready to talk or return to normal. They may be sitting alone, staring off, avoiding eye contact, or taking deep breaths. Then we go into post-crisis depletion. After all that emotional energy, the person feels totally drained. They may want to just sleep, cry, or sit in silence. It often feels a little bit like running a marathon. They just need time to rest and recover. You might see folks slouching, lying down, not responding to much, or saying that they're exhausted. And then we move into recovery. The person starts to feel a little bit more like themselves. They may be able to talk about what happened, reflect, even say they're sorry. They're on their way back to calm, but they may still need more support and patience from others. They may say things like, "I didn't mean for that to happen. I was just overwhelmed," or "Can I have some help?" The biggest takeaway here is that crisis is a process and that there are often opportunities to interrupt it before it reaches its peak. Knowing the person and understanding their MHAD allows an opportunity to help them in the early stages, like during the trigger or agitation phases. Let's move into the role of MHADs in crisis prevention. Although the primary function of an MHAD is to serve as direction during a crisis and when a person loses capacity, it can also be used to help prevent a crisis before it happens. We've talked about how a crisis often builds up in stages. With an MHAD, a person can write down what those early warning signs look like for them, like if they stop sleeping, feel panicked, or begin pulling away from others. Then they can include what's most likely to help them calm down, like listening to music, talking to a certain friend, or taking a walk. For example, a person might write in their MHAD, "When I start to shut down or stop texting back, I might be getting overwhelmed. When I can't sleep for more than a couple nights in a row, I'm starting to go into crisis mode." By having this information written down ahead of time, friends, family, helpers, or professionals can take action early. They don't have to guess what's going on or what the person needs. They already have the answers in the MHAD, and that early support can sometimes stop the situation from getting worse. Think of it like catching a spark before it becomes a full-blown fire. Waiting too long can lead to a crisis. Responding early and with the right tools can help to prevent the crisis altogether. So while the MHAD is helpful during and after a crisis, one of their biggest strengths is actually in crisis prevention. They help everyone, especially the person experiencing mental health challenges, stay a few steps ahead. MHADs can guide care teams to connect people with community-based resources that are already known to work well for them. These supports are especially important because they often can provide the right level of help without sending somebody to a hospital. As an example, someone may engage in outpatient care. If a person has a strong connection with an outpatient provider, like a therapist, psychiatrist, or case manager, the MHAD can direct care teams to that provider first. For example, adding an extra therapy session, adjusting medication, or scheduling a same-day check-in can help stabilize the situation. This allows the person to get trusted support from somebody who knows their history, often avoiding hospitalization. Crisis walk-in centers give people immediate access to trained staff in a calm, supportive space. The MHAD can direct somebody to a crisis walk-in where they are able to talk through what's happening, receive short-term treatment, and leave with a plan for ongoing care. For many, this is a less overwhelming and more effective option than inpatient treatment. Mobile crisis teams can help if someone is unable or unwilling to leave their home. An MHAD can specify that they prefer a mobile crisis intervention. This allows trained clinicians or peer support staff to meet them where they are, at home or work in the community. Getting help in a familiar environment can sometimes de-escalate a crisis more quickly and reduce the need for hospitalization. Many people identify peer supports and individuals with lived experience of mental health recovery as a key option for their support team. An MHAD can name peer support workers or programs as part of the crisis response plan. Having someone walk alongside them who truly understands can make the person feel safer, more respected, preventing the crisis from escalating to a hospitalization. Together, these options show how MHADs help people stay connected to care that works best for them. By clearly naming outpatient providers, walk-in centers, mobile crisis teams, or peers, an MHAD can help avoid unnecessary hospital stays while still ensuring the person receives meaningful, stabilizing support. Most importantly, it helps them stay in control of their care and avoid being placed in settings they don't want or that they don't need. Let's talk about when it's the right time to take out and use someone's MHAD to try to stop a crisis before it occurs. There are some clear warning signs that should make us pause and say, is this a good time to check the MHAD? These signs tell us that the person may be starting to struggle and may still have time to help them get support before things get worse. The first one is sudden behavioral changes. Maybe they stop taking care of themselves or begin acting in ways that feel really out of character for them. Someone who's usually quiet may suddenly become really agitated or start yelling a lot. Maybe they have a rapid increase in substance use. Maybe if something feels off, it probably is. And the MHAD may have some information about what to do next. Another big sign is expressions of distress or hopelessness. This can sound like people saying things like, "What's the point?" Or "I just can't do this anymore." It might also be less direct, like someone just seeming constantly down or overwhelmed. These are signs someone might be nearing a breaking point, and the MHAD can remind us what helps them feel safe, calm, or connected. Then there's withdrawal from usual activities. If someone suddenly stops showing up to work, school, appointments, or even everyday hangouts, that's a signal too. When people pull away from routines or relationships that usually keep them grounded, it can be one of the earliest signs that a crisis is coming. All of these signs are moments when the MHAD becomes really valuable because it can tell us who to call, what kinds of support to offer, and how to respond in a way that respects what the person says they need. By acting at these early stages, providers can often interrupt the crisis before it peaks, which is better for everyone involved, especially the person at the center. Next, let's talk about the role of MHADs in crisis intervention. When someone is in a crisis, the kind of help they get really matters. In fact, help can make things better or worse, depending on how it's given. If a helper pushes the wrong kind of support, even with good intentions, it might cause more stress, confusion, or even fear. That's why it's so important that helpers understand what the person needs and how to approach them and what to avoid. And when someone's in crisis, they may not be able to explain these things clearly in the moment. That's where the MHAD becomes a powerful tool. It gives everyone, family, first responders, hospital staff, or others, a clear picture of what works for the person and what doesn't. It helps take the guesswork out of care during one of the most stressful times. Also, keep in mind that a person in crisis often gets help from more than one team. They may interact with EMTs, a mobile crisis unit, a hospital team, or a therapist. And if these teams are not talking to each other, they might actually give care that doesn't match or that actually conflicts. One person may try a calming conversation while the other is using firm commands. These kinds of mismatches can be really upsetting for somebody in a crisis. People who get care that feels troubling may never engage in ongoing care again. This can result in the person having increased episodes of crisis and using high-cost services like law enforcement or emergency rooms on a regular basis. But if everyone's working from the same MHAD, they can stay on the same page. The MHAD tells all teams what the person says help them, what the person says makes things worse, and how to support them in a way that's safe, respectful, and effective. So during a crisis, the MHAD acts like a shared plan. It centers the person's voice, and it helps all providers work together instead of separately. An MHAD can guide providers during a crisis, and it's important to bring it into the conversation right away. When someone is in crisis, it can be hard for them to explain what they need or what they want in that moment. They may be scared, overwhelmed, or struggling to communicate clearly, but an MHAD gives providers a head start. It offers clear steps on how to support them based on what they already said works for them when they're well. For example, the MHAD might say things like, "I respond best when people speak calmly and give me space. Please don't call the police unless I'm physically unsafe." Following these directions can make a big difference. It can help the person feel calmer, safer, and more in control. And it can help avoid bigger, more serious steps like going to the hospital or being restrained. When support is given in a way that respects the person's MHAD, it can keep the situation from getting worse. But here's the challenge. When a person is in a crisis, they may not think to mention that they even have an MHAD. They may forget, feel too overwhelmed, or assume no one will care. That's why every provider should make it a routine practice to ask early on, do you have a mental health advance directive? Asking this question up front helps make sure the person's voice and preferences are part of the response right away, before decisions are made without their input that could lead to a trauma for the person and other poor outcomes. Now let's talk through a couple of legal considerations. The law says that MHADs should be followed to the full extent possible. That phrase, fullest extent possible, is key. It means that in general, a person's documented preferences for their mental health treatment must be respected and implemented. However, there are specific exemptions built into the law. These exceptions are safeguards. They exist to ensure care remains ethical, legal, and safe for everyone involved. Here are 4 conditions under which a provider may decline to follow an MHAD. First, if following the directive would mean violating the accepted standard of care, meaning it would go against what is professionally recognized as safe and effective treatment, then the provider is not obligated to comply. If the requested treatment would violate the law, the provider must refrain. No directive can override legal statutes. If the treatment specified in the MHAD simply is not available, whether due to facility limitations, staffing, or resources, the provider cannot be expected to deliver it. In the cases of emergency, if following the MHAD would endanger the life or health of the individual or others, the provider has the authority to act outside of the directive to protect safety. It's important to note that Washington law makes it clear that the legislature intends that failure to follow these guidelines can be grounds for a civil claim and for disciplinary action in regard to the provider's license. So, while MHADs are powerful tools for self-advocacy and planning, it's important to understand that they operate within a framework of clinical judgment, legal compliance, and real-world feasibility. Ultimately, the goal is to balance respect for the individual, their autonomy, with the responsibility to provide safe, lawful, and effective care. It's also important to talk about what happens when a mental health crisis escalates to the point of a hospitalization under the Involuntary Treatment Act. In these situations, the individual's MHAD may not be followed. This is because the legal framework of the Involuntary Treatment Act can override the preferences laid out in the MHAD. Specifically, if a provider determines that the preferences in the MHAD are inconsistent with the purpose of the commitment or with any related court orders, the MHAD is considered invalid for that period of treatment. That means the provider is not legally bound to follow it. However, even when the MHAD is deemed invalid, it still holds value. Providers can use it to advise treatment decisions, offering insight into the individual's preferences, history, and what's worked for them in the past. Again, ideally, the MHAD should be used before a crisis reaches the level of involuntary hospitalization. When implemented early, the MHAD can help de-escalate a situation and guide care in a way that aligns with the person's wishes, potentially preventing the need for Involuntary Treatment Act intervention altogether. An MHAD does not give an agent the power to admit a person into a hospital over the person's objection unless it's consented to in the MHAD. Only a judge or certain laws can decide when someone has to be admitted against their will. The agent can help speak on the person's behalf, but they cannot make the kind of legal decision alone. Note that in Washington state, a person can give the agent the power to admit them to a psychiatric hospital when they lack capacity, even if they're refusing in the moment. To do this, the person has to have an evaluation and they have to meet medical necessity requirements for admission. Now let's walk through what MHAD use looks like in a crisis response. An MHAD can guide providers during a crisis, and it's important to bring it into the conversation right away. When someone is in crisis, it can be hard for them to explain what they need or want in that moment. They might be scared, overwhelmed, or struggling to communicate clearly, but an MHAD gives providers a head start because it offers clear steps on how to support that person based on what they actually said works for them when they were well. Following these directions can make a big difference. It helps the person feel calmer, safer, and more in control. And it can help avoid bigger, more serious steps like going to the hospital or being restrained. When support is given in a way that respects the person's MHAD, it can help keep the situation from getting worse. One of the most important parts of the MHAD is the section about medications. When someone is in crisis, it's not always easy for them to explain what medications help them, which ones don't, or how they take them. But if that information is written in the MHAD, it gives providers a clear guide to follow. First, the MHAD can list medications that work best for the person. These are usually the medications that have helped them feel more stable in the past. Maybe they reduce anxiety, help with sleep, or manage symptoms like depression or hallucinations. By using medications the person already knows are helpful, providers can respond in a way that is familiar and safe. Next, the MHAD can include medications that should not be used. This is just as important. Some medications might have bad side effects, make symptoms worse, or have even caused trauma in the past. If someone has had a negative reaction to a certain medication before, they can write that in their MHAD so it doesn't happen again. The MHAD can have specific notes about how much medicine the person should take and how they prefer to take it. For example, it might say, I take this medication at bedtime with food, or please start with a half dose if I haven't had it in a while. These small details help providers give medication in a way that fits the person's usual routine and avoids surprises. This information can also help providers explore whether a person has not been taking their medications recently and whether this may be a contributing factor to the emerging crisis. If this is a factor, the team can work with the person to address this need and perhaps avoid hospitalization. The MHAD can include information about which providers or services a person already knows and trusts. This section is really important because it helps the care team avoid guessing during a crisis. Instead, the MHAD can point people directly to the providers and supports that are most helpful for the individual. For example, a person may write down the hospital that they want to go to if inpatient care is needed. Maybe they feel more comfortable at one hospital because the staff there has treated them with respect, or because they have a good track record of following the person's treatment plan. If the MHAD lists this preference, it helps first responders and providers honor the choice instead of sending the person to a hospital they don't want. The MHAD can also list specific doctors, nurses, therapists, or helpers that the person trusts. For instance, someone might write, please contact Dr. Smith at the community clinic. She knows my history and what treatments work best for me. That way, providers in the middle of a crisis know exactly who to reach out to. This can save time and reduce stress. Finally, the MHAD can include notes that help make sure care continues smoothly after the crisis ends. For example, the MHAD might say, make sure to schedule a follow-up appointment with my outpatient therapist within 1 week of leaving the hospital. Or it might say, please give me a list of peer support groups in my area before discharge. These details keep recovery moving forward and lower the chance of another crisis happening soon. By including this kind of information, the MHAD helps make sure the person's care is safe, familiar, trusted, and consistent. MHADs often list people who can help step in and support a person during a crisis. This section is important because when someone is struggling, they may not be able to reach out or explain who should be contacted, but the MHAD already has that information ready. It usually includes names, roles, and phone numbers of key people. These could be family members, close friends, care managers, therapists, or peer supporters, or the agent, anyone the person trusts to help when things are hard. This makes it easy for providers or crisis teams to know exactly who to call. The MHAD may also have a description of how each person can help. For example, it might say, my sister can explain my triggers to the crisis team. My peer support person knows how to calm me down if I'm panicking. Please call my friend who can bring my medications or help me get home. This kind of detail helps responders know not just who to call, but why that person is helpful and how to bring them into the situation into the best way. Finally, the MHAD often lists one main emergency contact and a backup. In this case, in the case that the first person cannot be reached, this helps make sure that there's always somebody available who knows the person, cares about them, and can help advocate for their needs. In addition to listing people who can help during a crisis, the MHAD can include who should be kept informed about the person's care and how that communication should happen. During a crisis, the person may not be able to explain who should get updates or how they want information shared. This is why it's so helpful when the MHAD already includes this information. For example, the MHAD might list who should get updates if something happens, like a parent, partner, friend, case manager. These are the people the person trusts to know what's going on and who can help support the recovery. You can also say how these people should be contacted. Some people want a phone call, others may prefer a text message, and some may want in-person conversations only. Including these preferences helps make sure that the person's support network is contacted in a way that feels right for them. And just as important, the MHAD can list anything the person wants to keep private, things that should not be shared with certain people. For example, someone might say, I want my mom to know I'm safe, but please don't talk to her about my medication. This kind of guidance helps everyone involved, providers, crisis teams, and supporters, honor the person's boundaries while still keeping key people in the loop. It's important to note that for any of this information to be shared legally, the person must complete the proper release of information forms. Without those, providers may not be able to contact others, even if it's written in the MHAD. It's a good idea to check that those forms are signed and up to date and match the MHAD. Crisis care is never one size fits all, and that is especially true when it comes to cultural needs. One of the most powerful ways to show respect and build trust is by making sure the care provided matches the cultural values of the person and their lived experience. When providers take time to ask about cultural preferences and then honor those preferences whenever possible, it leads to better outcomes and more humane care. These details are often written directly into a person's MHAD, so it's important to review the MHAD carefully before making assumptions. Regardless of whether it's in the MHAD, providers should take the time to ask clarifying questions to best understand how to support a person's cultural needs. Here are a few cultural considerations to keep in mind. Does the person have a preference for the gender or background of the provider? For example, a woman who has experienced trauma may feel safer with a female provider. A person from an Indigenous background may prefer someone familiar with their tribal customs or their legal systems. If you can't meet this preference, how can you still make that person feel safe and respected? It could include things like letting the person know why you can't meet the request. Saying something like, "We unfortunately don't have a woman doctor on the unit today. Is there another way I could help you feel safe, perhaps by having a woman therapist in the room with you while you're talking with the doctor?" Asking them what would help them feel more at ease in the moment. Avoiding touch or eye contact if those are culturally inappropriate. You can also ask what the person's faith-based preferences are. Should prayer, spiritual items, or faith leaders be part of their care or specifically left out? For instance, some people may request a quiet space to pray or a particular ritual before taking medications. The provider can say things like, "Would you like me to contact a spiritual support person for you? Is there anything you don't want involved in your care, like certain types of prayers or groups that focus on religion?" You also want to ask about dietary needs or restrictions. This could include kosher, halal, vegetarian, or allergy-related needs. All agencies should have a process in place to make sure dietary accommodations are able to be made as needed, ensuring that adjusted meals are just as nourishing as regular options. We also want to ask if there's specific cultural considerations for their care. Some cultures have clear guidelines that may impact care provided inside or outside a hospital. It's important to ask about these. A provider can say, "Are there any specific ways your care needs to be handled based on your cultural rules or customs?" We also want to make sure to ask about tribal, community, or jurisdictional issues to consider. For Indigenous individuals, this might involve contacting a tribal authority or respecting sovereignty-based healthcare guidelines. These questions are essential. Every person brings a unique identity, set of beliefs, and history into the crisis setting. Guessing or ignoring these things can create harm, which is why it's so important to look at the person's MHAD and whether these are addressed. These issues also highlight why providers should also be trained on how to show cultural humility and respect in their work, and how to learn about the needs of different groups in their own communities, whether that means learning from patients, peers, or local leaders. Now let's talk through how to overcome barriers to MHAD implementation. It's not enough to just know what an MHAD is. Providers need to be trained on how to talk about them, help people create them, and make sure they're actually used. This is especially true for teams working in crisis care, outpatient services, hospitals, and community-based programs. First, providers should teach crisis teams what MHADs are and how to use them. Crisis responders may not know how to spot an MHAD or how to use it effectively. Behavioral health agencies should offer training and reminders that MHADs are legal tools that should be followed. Second, providers should make sure MHADs are added to a person's medical records. An MHAD is only useful if the right people can find it. Providers should always ask for a copy and make sure it's uploaded in the person's electronic health record, especially in places like the ER, outpatient clinics, or mobile crisis units. This ensures the plan can be seen and used when it's needed most. Third, providers should always ask if someone has an MHAD during emergencies. This should be a standard question during intake or crisis response, just like asking about allergies or medications. For example, "Do you have a mental health advanced directive you'd like us to follow today?" Even if the person can't speak clearly, someone on their team or support person might have a copy ready to share. Finally, providers should help people create an MHAD if they don't have one and are stable enough to do so. Providers can play a powerful role in prevention by helping people build an MHAD when things are calm. This can be part of outpatient therapy, discharge planning, or peer support. It's a chance to ask, have you ever thought about writing a plan for how you want to be supported if you experience a crisis? Let's talk through post-crisis review and MHAD revisions. After a crisis, one of the most important things to do is take time to ask, how well did the MHAD work? The goal is not to judge or blame, it's to learn. Reflecting after a crisis helps make sure that MHAD stays useful, up to date, and centered on what truly helps the person. Start with this question: what parts of the plan helped? Ask things like, was there anything in the MHAD that seemed to calm things down? Did staff or crisis responders follow anything from the plan that made things easier? Was there a support person listed who was especially helpful when contacted? Then move on to the next question. Which parts of the plan weren't as effective as we had hoped? Ask, was there anything we included in the plan that didn't really help in the moment? Did someone try a calming strategy that didn't work? Was medication used that didn't seem to help or cause a side effect? Next, ask the person about their overall experience. How did they feel after it was all over? Use questions like, did you feel heard and respected? Did it feel like the team listened to what you said in the plan? What would you want to be different if this happens again? Finally, ask, what changes do we want to make to the MHAD? Think about, are there people we should add or remove as emergency contacts? Should we update medication instructions or crisis strategies? Do we need to be clearer about where the MHAD should be sent or stored? This kind of check-in doesn't have to take long, but it can make a big difference. It helps the person feel empowered and reminds everyone that the MHAD is a living plan. An MHAD is not a one-time document. It should grow and change as the person grows and changes. That's why it's important to check in on it regularly. Here are some helpful ways to make sure that MHAD stays useful and everyone involved knows what's in it. Look over the MHAD a few times a year. This helps make sure that everything in it is up to date and still makes sense. These check-ins don't need to be formal. They can happen during regular appointments or planning sessions. Next, make sure everyone who needs a copy gets one. This includes agents, trusted family members, doctors, therapists, and even school staff if appropriate. This helps prevent confusion and make sure everyone is working from the same plan. If possible, bring the care team together for a conversation. This might be through a case conference, wraparound meeting, or just a scheduled check-in with key supporters. In that meeting, the person can share what's working, what they want to change, and how everyone can help them stick to their preferences if a crisis happens again. These steps help the MHAD stay strong and useful. When the right people are informed and the plan is clear, it's much more likely that the person's voice will be honored during tough moments. And just as importantly, it shows the person that their care team is listening, respecting their wishes, and working together. The next slides contain a few resources that might be helpful as you expand your knowledge on mental health advanced directives. To learn more, please explore the additional training topics linked on this slide. Here are crisis support lines that are available for the public, including the 988 Suicide and Crisis Lifeline, Native and Strong Lifeline, and the Native Resource Hub. And here is a robust list of varying resources that help a person learn more about mental health advanced directives, also known as psychiatric advanced directives, and Washington law in relation to mental health advanced directives. If you have questions, please use the link on this slide to contact HCA and check out more information on the HCA MHAD website. Thank you.